Hey everyone, it's Izzy. For Learning Objective 4, I'm going to talk about the pathophysiologic abnormalities we would find in a female patient with a microprolactinoma. And then clinically, we'll talk about epidemiology, how these patients might present, and how we would manage them, and what diagnostic evaluation tools we could use. So when someone has a microprolactinoma, what happens is that the tumor itself secretes excessive prolactin. So most of the dysfunction and abnormalities we'll talk about stem from this hyperprolactinemia state. So in females specifically, too much prolactin can disrupt several really important reproductive and just overall well-being sort of levels. One thing that happens is dysfunction in the hypothalamic pituitary gonadal axis. So when there's disruption here due to that excessive prolactin, you'll have decreased GnRH. And we know that we need GnRH to kind of have that pulsatile fashion, so that way we could have FSH and LH, which contribute to eventual follicular maturation and the ability to then carry out a pregnancy ultimately. So in these patients, when you don't have the GnRH, you're then going to have decreased FSH and LH. And overall, this leads to lack of or decreased estrogen and testosterone, and ultimately leads to ovarian dysfunction. And what can happen is that they might not ovulate at all, so anovulation, and then they might show up to you for infertility. So this kind of highlights how I'll talk about later how microprolactinomas tend to be found incidentally, but maybe a chief complaint of infertility could be one reason you start investigating this. So with that, not enough estrogen, so hypoestrogenism, is because of that suppression of the GnRH, LH, and FSH. And so then your ovaries aren't really being told to produce the estrogen that they should. And so what happens here is patients may show up with amenorrhea, so lack of menstruation, or oligomenorrhea, which is really not regular menstruation. Other abnormalities you might see in a patient is galactorrhea, so milk production due to that excess prolactin. And this can just be inappropriate lactation in a state that you wouldn't really expect them to be producing milk. Another risk is bone density loss. So we need the protective factors of estrogen to help combat risk for osteopenia and osteoporosis. And other things that your patients might show up with would be mood disturbances or issues with sexual function. So without the efficient estrogen being produced, you'll have decreased libido. Patients might even come in for a chief complaint of depression, which is interesting considering our chief complaint for doctoring this week was that. Epidemiology of prolactinomas in general is that they account for about 40% of all clinically recognized pituitary adenomas. And what happens within that 40% is there's a mean prevalence of about 10 per 100,000 in men and about 30 per 100,000 in women. In women specifically, the peak prevalence is reproductive age, so 25 to 34. And then within that category of prolactinomas, the subset of microprolactinomas is that there's as many of 60% of prolactinomas. Sorry, you got to follow me here a little bit, but 60% of prolactinomas in males are microprolactinomas. And then in females, 90% of those prolactinomas are microprolactinomas. I could have worded that better, but I think you guys follow. So the clinical presentation for a microprolactinoma, like talked about earlier, microprolactinomas themselves are usually found incidentally on some sort of neuroimaging and really just not necessarily at the top of a differential, so to speak. Prolactinomas, though, they can be, typically they'll present maybe mostly due to mass effect of the tumor itself, or the issues stemming from hyperprolactinemia, which can be the same for the microprolactinoma. They might be showing up with symptoms stemming from hyperprolactinemia. And I like this little photo on the right here. So you can see some different signs and symptoms you might see stemming from hyperprolactinemia in males, females, and children or adolescents. And then this imaging is nice too, because you can kind of see the microprolactinoma right there. Clinical presentation continued. One emergency situation we want to be aware of is pituitary apoplexy. So this is spontaneous hemorrhage into the pituitary tumor. So a patient might be presenting with a really severe headache, vision changes. You might see just overall decreased pituitary hormones on labs. So that's something to keep in mind. ROS questions or physical exam findings we could kind of link with mass effect is headaches, vision changes as discussed, but digging a little deeper with any visual field deficits, blurred vision, decreased acuity. On physical exam, you might want to keep out for any cranial nerve palsies and ask the patient if they've experienced seizures. So differential, we could kind of group this in physiological causes. So pregnancy can lead to a state of hyperprolactin, nipple stimulation in lactating women, or stress. And then pathologically, we could have various hypothalamic disorders, if they've ever had radiation to their head, and sarcoidosis. Drugs that can cause this, dopamine antagonists, so certain antipsychotics, tricyclic antidepressants, SSRIs, certain antiemetics. I put metoclopramide there. There are a few others. I didn't finish that thought. And then opioid analgesics, so morphine or methadone. On labs, we'll want to get their serum prolactin levels. So if it's high, then we're going to investigate even further with a CMP, TSH, and get a pregnancy test in a female. We will also want to look at cortisol, ACTH, IGF-1, LH, FSH, testosterone, and estrogen. And one thing to keep in mind is something called the hook effect. So a patient could have really high prolactin, but when you get your labs back, they'll measure really low. So if you suspect this, if all your other clinical judgment is pointing to some sort of microprolactinoma or hyperprolactinemia state, just go ahead and you can repeat it, remeasure the sample so it can be diluted. The serum sample can be diluted and remeasured. So again, just always trusting your clinical judgment because there are lab errors. Imaging, on a CT, you could see a mass, but the gold standard is MRI with gadolinium. And CT could show you, I mean, MRI is the go-to, but CT, unless there's like profuse intracranial hemorrhage, then it's not going to be as sensitive. And then we'll want to get them formal visual field testing, which I was reading can be done with ophthalmology, but I'm not familiar with what they do beyond what we're taught. So that's a point of, I guess, investigation for us all. And then we would start the patient on some sort of dopamine agonist, so cabergoline, and we had this in our case. So that's the preferred one. For my research paper, I selected a paper by Weinreich et al. In the European Journal of Endocrinology, published in 2021. So the paper is called Apoplexy of Microprolactinomas During Pregnancy, a report of 5 cases and review of the literature. So I thought this was interesting because one of the medical emergencies mentioned was apoplexy. So this paper, they looked at 5 cases of women with microprolactinoma who then experienced pituitary apoplexy during their pregnancy. Of the 5 cases, only one of them ended up needing surgery during their pregnancy, and the others were treated more conservatively and reintroduced dopamine agonists. And so kind of, I guess the interest for me was because usually I think during the pregnancy, dopamine agonists aren't going to be administered, but in this case, you kind of had to weigh your pros and cons, and having the more conservative method saves patients from having to get surgery. So yeah, that was my interesting paper. And if anyone has any questions, oops, there are my references. But if there are any questions, please feel free to text me in our group chat or just let me know next week. All right, thank you all.